Welcome to our official 21st Steinberg-Bernstein minimally invasive surgery visiting professorship and our first virtual professorship. And I'm really delighted to welcome Dr. Eric Pauli, who comes to us from Penn State Hershey Medical Center. He's professor of surgery there and serves as the chief of the Division of Minimally Invasive and Bariatric Surgery. His real clinical areas of interest are abdominal wall reconstruction and therapeutic flexible endoscopy. His Twitter says something like he fixes holes in things and makes them sometimes, and I think that's a pretty accurate description of what we as surgeons do sometimes. Dr. Pauli is maybe one of our youngest visiting professors, but certainly not the least accomplished. He's the recipient of numerous awards, lots of SAGES Research Awards, the SAGES Young Researcher Award, and lots of awards for really teaching and innovation. He's got inventions and patents to his name, has done, he just said at the beginning of this talk, thousands of virtual presentations already, and this COVID thing has only been going on for a few months. So I think, that's a testament to his sort of interest and of course, I think expertise in his clinical areas and also his interest in teaching. And so I'm delighted to welcome him here to McGill for a delightful afternoon of a talk from him, followed by presentations from our residents and fellows and faculty in our Department of Minimally Invasive Surgery. Before you get started, Dr. Pauli, I just want to, first of all, extend our thanks to our sponsors, Medtronic, Lynn, if you're there, welcome, and of course, Carl Stortz. Eric, if you're there, thank you very much as well. And of course, thank you to Peppa and to Maria for putting this all together and organizing all of this. It does take a lot of work to put something like this together, even if it is all virtual. And I really appreciate all the efforts that you've put in. One small comment about logistics. So once we will be recording your talk, Dr. Pauli, if that's okay with you, and make that available for people who weren't able to make it, who want to review things later. But we won't be recording the rest of the day just because it'll just make a file that's just unusable. But we will try to keep the rest of the day on time. If people have questions, there are two options. One is to write them in the chat and the moderators will help to moderate that. Or there's a raise your hand function. If you click on the little people in the participant section, there's on the bottom there's a blue hand. And if you click on that, we'll try to, when there's a lot of people, sometimes it's hard for us to see that. So if you have raised your hand and you're not being called upon, by all means, put it in the chat or speak up or do something to make it known because we don't want to miss you. And so without further ado, I do want to thank Dr. Pauli for being here. He is officially on vacation, but agreed to do this for us. And I think that's really, we're very lucky to have you. So welcome and go ahead.
Well, thank you very much, Elena. That's a really great introduction. I do appreciate being with you guys virtually. I do want to say I've actually never been to Montreal. I've been to a lot of different cities. Never been to LA either, but Montreal is on the list of places that I want to go. So what I did do is I did try to decorate a little bit so that it at least feels a little bit, Canadian here, okay? So my father-in-law used to own a company and they actually had box seats at the Canadians for years. I never got to go with him, but he did. That's a signed Patrick Waugh jersey there for those of you who, I guess a sweater is what I should be calling it. Well, again, I wanted to say thank you. It's really humbling to look at the list of people who you guys have had as your visiting professors before me. Many of whom are have name brand recognition, and many of whom I'm fortunate enough to call friends. And it's also delightful to look at this whole panel of pictures in front of me here and see friendly faces, even if it's virtually. I'm going to share my screen here. Let's give you that screen there. And hopefully you guys can see my slides. I'm going to spend the first sort of maybe 45 minutes here talking about abdominal wall imaging and planning a successful hernia repair. This is, part and parcel to my interest in abdominal wall reconstructive operations. I have the pleasure of talking about imaging, quite often, and this is a thing that I do ultimately quite regularly. I'm on vacation this week, and I've already had 3 or 4 people just sort of send me text messages of CAT scans that said, "Hey, can you look at the scan and tell me like what you think is going on?" Actually, one of those scans was somebody taking their a recertification of a board exam. They were like, "What is this CAT scan supposed to be?" And I'm not really sure I'm supposed to help you with that. These are my disclosures, none of which really have any bearing on what we're talking about. I do speak for some mesh companies, and you will see in the talk some brand names of mesh. I'm not making any recommendations about any products today. This is a sketch from a Rembrandt painting. About this time last year, I had the pleasure of going to visit my good friend Philip Moysens, who runs a hernia center in Belgium. And I spent some time actually with some other hernia surgeons, including your speaker at this conference from 2 years ago, Dr. Archana Ramaswamy, in Amsterdam. And we spent some time at some of the museums there looking at Rembrandt sketches. And this, what I like about this black and white photo is that the subject matter and the title of this is actually the baby walker. The idea here is that the stuff that's in the foreground of this black and white image is really not what Rembrandt felt was the most important part of this picture. In fact, he painted this as a reminder to his pupils that you can master your craft through constant practice. And what I hope to show you guys today is that as we talk about and think about imaging in hernia patients, looking at these scans ahead of time, coming together with a good plan is really the best way, I think, to become truly a master at abdominal imaging. So why do we care about this? Well, we care about this because hernias, as we know, come in a variety of shapes and sizes, right? This is a patient of mine from about a year ago who has an umbilical hernia. This is just an umbilical hernia. There's his umbilical stalk right there. You can actually see all of that content is out from just an umbilical defect. This is another patient who has a teeny tiny little umbilical hernia that bothers her and a small diastasis. These are just both umbilical hernias, but obviously the management and the strategy about these is going to be very different. One of these patients is going to get a very large open abdominal wall reconstructive procedure, which if you plan it out well enough and do the right things, you can get some fascial closure. The other patient is going to get something that's minimally invasive. And in fact, this patient got a scola procedure where we do subcutaneous ports and lift up a big skin flap. You can then define the linea alba. You can suture it closed, closing the hernia defect, and ultimately place mesh to close this in an onlay fashion. So very different. And I think what these two cases illustrate is really the sort of the problem of modern hernia surgery is there's just too many options, right? We've got open, lap, robot, hybrid. You can place your mesh in a variety of different abdominal cavities. You could use mesh or not use mesh. What kind of mesh do you want to use? Are we using a synthetic or a biologic or a bioabsorbable? Which type of synthetic, which brand name are we going to choose? Which actual abdominal plane are we going to work in? Underlay, sublay, and there's obviously multiple different options for sublay repairs nowadays, including retromuscular, pretransversalis, preperitoneal. And are we going to close the defect or not? And when you put all of these combination of things together, you come up with many, many thousands and thousands of different ways you can take the same operation and do it very differently. And so what that means is that a small umbilical hernia can be addressed in a variety of different fashions. All of these are acceptable options for managing that small umbilical defect. And so, part of the planning for any of these operations is the thing that we all talk about, which is the recipe for success, which, has a couple different ingredients. We want to do the right patient at the right time. And that includes some patient optimization. And we're going to, I think, have some people talk about hernia optimization later on in the day today. So that'll be a nice segue there. You can talk about prehabilitation. We want to talk about mesh choice, and obviously understanding material sciences is a huge part of how successful hernia surgeons are successful. And some of that is based off of, understanding your mesh options that are available locally. And some of that is determining whether, your plan going in based on intraoperative factors is right. But obviously you want to plan and choose the right operation. And the right operation for me is something that is not only based off of what you do technically well, And again, we're going to have some talks later on today about how to train and how to get people prepared to do surgical procedures. But for me, it's about an anatomic pre-evaluation of the patient, which relies extremely heavily on imaging. And so that's why we're going to spend, the rest of this talk focused on imaging. So you might ask yourself, why is this guy who is a surgeon who does a lot of endoscopy giving a talk on imaging? Well, I actually learned all of my anatomy on CT scans. As a high school and college student, I used to work in X-ray files as a file clerk. And the radiologists who worked there recognized that I wanted to go to medical school. And I think they found it kind of fun to teach me how to read imaging studies. So I would hang the films up, and they were actual films that we would hang. And then they would show me, like, this is a liver, and this is a spleen, and this is an abnormal liver. And so by the time I got to anatomy lab, I actually kind of understood relationships of organs, at least on imaging. And I could, in my head, kind of scroll up and down through that virtual CAT scan of the stuff I was looking at in front of me. So I kind of had these mental roadmaps outlined before I ever saw these things in real life. And that obviously made me super helpful when I was a resident, because at nighttime, some nights I may have been the best radiology resident in the building. And so if I looked at a film ahead of time, even if I completely disagreed with what the radiologist resident said, I was going to call my staff member and say, listen, I'm looking at the films myself, and this is what I really think is going on. As I became more interested in minimally invasive surgery and in operations that happen on a television screen, kind of remote from my hands, I realized that I was using those skills of scrolling up and down, of understanding anatomic relations of things that weren't even on the screen to my advantage. So I was making these operative roadmaps. And now, as I mentioned earlier, I get the opportunity to look at a lot of scans, not only in my practice, but my partners find me, even if it's not a hernia-related CT scan. And people email me and text me and WhatsApp me and Facebook message me imaging studies to say, hey, can you look at this study and tell me what's going on? And, I think ultimately, if you can help somebody who's your friend across the country look at a CT scan for a bowel obstruction on your phone and give them a diagnosis, you ultimately get really good at doing these things. So how do we use imaging and hernia repairs? I think a lot of this is obviously kind of common sense for surgeons. I've already mentioned the preoperative planning phase. I use them very heavily for intraoperative assistance as well. I will, take a timeout in the middle of the operation if I'm at a very challenging area in the dissection, and I will go and look at the scan and say, hey, what's actually going on here? Now that I got my hands and my eyes on the inside, how does that correlate with areas on the scan that may have been unclear early on? And I will use that to help and guide my dissection to say, look, I'm going to avoid this area for a little bit so that I don't have an enterotomy. I'm going to come back to that a little bit later on. Obviously, the post-operative diagnosis and management of complications is going to be, part of how we use these. And we're going to, I think, have a talk a little later on about how long should you follow your hernia patients for wound complications. And so some of this is based off of imaging studies as well. Obviously, the long-term documentation of recurrence rates and long-term follow-up imaging is very helpful. And as a general rule, CT scans, which is what we're going to focus a lot on today, are the most useful. So why is that? Well, CT scans are widely available, and as general surgeons, we use these things a lot for a lot of the other diseases that are not hernia that we manage. You get nice visualization of intra-abdominal organs and the abdominal wall stuff, so you can look at several things at the same time. These are relatively inexpensive in the grand scheme of imaging studies, and they are not user dependent. And by that, I mean, I get a lot of referrals. If a patient brings me a disc with a CAT scan, I can plug it into my computer and I can look at it without worry that somehow they miscaptured the information. That is very different than ultrasounds, where you need to have a very good technician doing the protocol correctly. There is radiation involved, obviously, and we do probably over-radiate patients nowadays, just something to keep in mind, although a modern CT scan has really reduced amounts of radiation overall. These can also be pseudodynamic. For small hernias or bulges, you can ask the patient to Valsalva, to push out their hernia, and then stay stable and actually get a really good idea of what's happening under sort of actual physiologic conditions. MRIs, do have utility for the abdominal wall. There are fewer MRI machines in the US and Canada than there are CT scans, so they're certainly less available. I think the biggest problem is that for many general surgeons, we are not used to looking at MRIs. Unless you're a hepatobiliary or pancreatic surgeon, where MRIs are the imaging du jour for those specialties. I'm not used to looking at MRIs very often in my general surgical practice. Just like CTs, you can look at the abdominal wall and intra-abdominal organs. This MRI that I'm showing you actually has a couple fun things on it, including this big seroma. But also, if you look at the abdominal wall on some of the cross-sectional and sagittal imaging, you'll actually see this patient has visible mesh in place, which I'll talk about later on. You'll see the visible mesh here on these cuts. These are expensive, but like CT scans are not user dependent. No radiation, but obviously some patients, who have implanted devices can't get them. And these can also be dynamic. And so you can actually get real-time imaging on an MRI of a patient doing a Valsalva and pushing out their hernia to identify small or clinically non-palpable hernias. Ultrasounds are the most widely available, and many hernia surgeons keep ultrasound machines in their practice to actually ultrasound patients in clinic. Here we see a nice ultrasound of the abdominal wall. This is a left rectus, and you'll see that this patient actually has a very wide diastasis of the rectus abdominis here in the midline. I say these are semi-familiar for surgeons because many surgeons, like breast surgeons, endocrine surgeons, trauma surgeons, utilize ultrasound on a pretty frequent basis as part of their practice. And so if you understand the basics of ultrasound, doing an abdominal wall ultrasound is not all that hard to do. You can visualize the abdominal wall, plus, some intra-abdominal organs. You can see in this imaging, there's a lot of signal loss as a consequence of the bowel gas in the loops of bowel below. And I think the other thing you'll notice is, depending on the size of the imaging probe you're using, you may not get the entire abdominal wall or the entire defect in one single cut of the imaging studies. But these are not expensive. There's no radiation, and they can be very, very dynamic. You can actually make a nice video loop of a patient valsalvaing to show you where their hernias are. But these are extremely, extremely user dependent. And what that means is that a lot of times, if your tech is not particularly good at doing the specific ultrasound exam in question, you're going to get results that are interpreted by the radiologist the same way that the tech interpreted them, which is ultimately how these reports are generated. And there may not be a hernia on the exam at all. There are protocols out there. This is a protocol that Ben Paulus and his group, when he was in Knoxville, recommended in terms of how to do a complete abdominal wall ultrasound image, swiping in rows from top to bottom, and then left and then right. So there are protocols for these things as well. Focusing on CT scans, and we'll include MRIs in this as well. The application of these imaging studies for hernias is extremely common, and the techniques we use to inquire them are, for the most part, standardized. The biggest problem I think that we face is that the reports are in no way standardized. And what that means is there are problems with the reports that I think surgeons need to be aware of. And for those of you who do hernia, this is an everyday occurrence. We know that there is a high disconcordance rate, about 70%, review of imaging studies between radiologists and surgeons. We also know that hernias are the second most common structure to be inaccurately reported. Think back to the times when you've seen somebody measure the hernia sac and give you those dimensions instead of the actual fascial defect, which is what we care about. Hernias are also the most common missed pathologic finding on imaging studies of the abdominal wall. So many times I get patients referred to my clinic with an imaging study that clearly has a hernia on it and a report that says nothing about a hernia. And so the patient is there for basically a second opinion, which is ultimately a first opinion. Yeah, you got a hernia. It's here on the study. It just was misinterpreted. If any of you belong to the International Hernia Collaboration on Facebook, you'll oftentimes see people post their imaging studies. And that the thing that I just described really is an everyday occurrence. So here's a imaging study that this poster listed as on my clinical impression was incisional hernia, but these images were interpreted as bilateral rectus diastasis with herniation of fat only. What are your thoughts? Well, my thoughts are, here are some rectus muscles, and here's a big hernia sac with some loops of small bowel underneath. And I honestly don't know how this could be interpreted any other way. And the comments section, which is where the gold is on all of these posts, need new radiologists. Well, okay. That's one attitude to take. But the second comment I think is better, which is, you have to call them and teach them terminology, and they will amend the report. And so, this is a strategy that I took very early on here at my institution. I would call and review images with my radiologists. I don't do that so often anymore. A, because I think that they have gotten a lot better in terms of crafting the reports the way we want them. But I think number two is, unless there's something grossly wrong with the read, I'm not too concerned about doing an operation on somebody with a report that maybe doesn't even say there's a hernia there, because it's clearly there. My anatomic pre-op evaluation then of a patient includes obviously my physical examination, and then the abdominal wall imaging, but also the old operative notes. And the operative notes for me are the thing that makes how I look at an imaging study very, very different than how a radiologist does. So the op note is going to tell you a lot of really important stuff. So for example, what other hernia operations are being described? For example, this left paramedian juxta umbilical ventral abdominal hernia incisional, right? Obviously, we all understand what that means. When I look at a report like this, all I know is that's a lot of words being used to describe an M3 zone incisional hernia, okay? This tells me a lot not only about the surgeon who did this operation, but maybe about the quality of the hernia repair as well. But these reports will tell you a lot of information. For example, did they use mesh? Sometimes you can actually tell what type of mesh was used, although we looked retrospectively at a study of our own patients, and the most commonly used mesh at our institution in referral op notes was appropriately sized mesh. That was the type of mesh that was used. You can also figure out where the mesh was placed. And again, this is helpful to know, what anatomic planes were violated. And then I can look at the CT scan and figure out not only, hey, look at this, in the plane where they said they put mesh, there is actually mesh, which I missed on my first pass on the CT scan. You can also learn some other stuff like how hard was the adhesiolysis, were there any enterotomies or bowel resections, and then you can correlate those with the imaging studies as well. So what about physical exam versus CT scan? Well, as I said earlier, I use these to augment each other. One cannot replace the other, but physical examination alone misses almost 25% of hernias. For patients who have already had a repair, who have thickened scars, who might be morbidly obese, these can be very challenging to identify. But there are obviously things that you will never see on an exam that are present clearly on imaging, and vice versa. There are obviously things you're going to find on your exam that a CT scan has no chance of detecting, and you can't really blame your radiologists for that. So, these are patients who I met in my practice who had imaging studies that made no mention of the problems you see here on physical exam, like exposed infected mesh or like an obvious enterocutaneous fistula here. If you look at the scans yourself, you'll miss them as well. It's not until you look at the patient and the scan together that you're going to find it. How about this patient? This patient has imaging studies that show small areas of inflammation near the border of the right rectus that correlate with this area on physical exam, which when we look a little more closely, has some pus coming out of it. And obviously, if we look a little bit lower down, we can actually see multifilament polyester mesh that has MRSA on it. This is not reported on the CT scan, but it's also not visible on the CT scan. It's not until you have the patient in front of you that you can find it. So what else is on the CT scan that we use for preoperative planning? Well, we want to know how big is the defect. We also want to think about how wide are the rectus muscles, because that's going to help us figure out what type of potentially retromuscular hernia repair we're going to do. Where is the defect located? In this example, the defect actually abuts the xiphoid, so a high M1 zone defect. Is it lateral near bony landmarks like the costal margin or the confines of the bony pelvis? All of those are going to be treated differently. This patient has actually two defects. We see a midline defect here, and we see an old ostomy site defect here. This is important to identify, because if you think about the amount of overlap you're going to have in a retrorectus position for this defect alone, this is clearly going to be insufficient overlap. And so if I'm planning a retromuscular operation, I've got to be prepared to do something extra on this side, maybe a release of the transversus abdominis, to get lateral overlap for this defect. That's very different than the right-hand side, where we've got a very wide, at least 8 centimeter wide rectus here to provide overlap for the midline. So now we're planning for additional maneuvers. We also talk about this Carbonyl ratio, which is understanding that if you're planning a retrorectus operation alone, you've got to look at the size of the rectus muscles and compare those to the size of the defect. In this publication by Carbonyl from Greenville, South Carolina, written by Love et al. Will actually be out later this year. It's actually online for the first time in hernia, I think just last month. but it talks about looking at this ratio to plan whether a patient is going to get just a retrorectus operation or whether additional separations of components is going to be necessary. We also look for loss of domain. And again, there are formulas like this formula by Tanaka, which is the most commonly used formula that people talk about to determine loss of domain. Recent literature from the group at Cleveland Clinic kind of looked at, you can look at these formulas for loss of domain and figure out a volume ratio between the hernia sac and the intra-abdominal volume, but they're not really predictive of your ability to actually get the fascia closed utilizing modern component separation techniques. And so I think while these are interesting to know how to do, correlating these to an outcome is not something that we do very well yet. There are additional CT-specific considerations that I look at. I do spend a little bit of time thinking about the fat distribution. And if you look at these two CT scans, these are two very different patients, right? Look at the amount of subcutaneous fat on the patient on the right versus the patient on the left. Look at the shape and distribution of the rectus abdominis muscles. The patient on the left has these very balled up rectus muscles that have been disinserted. The patient on the right, they're still kind of flat and more lenticular shaped. The lateral abdominal wall musculature, that patient on the left-hand side has very thick, very taut musculature. This is to look at it, a very non-compliant abdominal wall. Look at the patient on the right. This patient has what we call the saggy lateral sign, where if you pull that tight, you can tell that this defect in the midline is going to come together. And you can also look for measures of sarcopenia, fat distribution within the muscle, right? The patient if you're going to order a steak, you really want the patient on the right-hand side that's really good marbling. But if you're going to do a hernia repair, that patient has signs of frailty and intra-abdominal intramuscular fat distribution that suggests that they may not have the best outcome. We talked about where defects are located. Subxiphoid defects like this big, almost 9 centimeter subxiphoid defect are a challenge to close. My former fellow is doing a TAR today, and she called me to look at the films just yesterday on a patient with a 10 centimeter subxiphoid, and I told her, I don't think it's going to close just based on that CT scan. So I'm waiting for her to call me back and tell me whether I was right or not. We can also look at imaging studies and muscle distribution and look at denervation. I'm not going to get too much into this other than to say, we do see a lot of patients who come to us with a complaint of a bulge that's not a hernia. Look at the right-sided rectus abdominis here. Look at how nice and thick that is. And now look at the left side rectus abdominis here. We have almost no muscle mass here as a consequence of some injury to the neurovascular bundles that come towards this rectus abdominis muscle. This patient does not have a hernia, and it's not a thing that I can necessarily fix with a hernia operation. Look at this patient. This patient came to see me in a wheelchair with a peristomal hernia, and I looked at his scan and I said, he has complete denervation of all of his muscles, right? He's got no rectus. He's got no lateral muscles. He's got no gluteus muscle. He's got no paraspinal muscles. He's got an iliacus and a psoas. But we looked at it and said, something's wrong. And we talked with him and he's like, yeah, ever since I got this stoma, I've had progressive weakness. And we sent him to our neurology team and they actually diagnosed him with a progressive myelopathy. So we were the first people to kind of comment on his overall lack of musculature radiographically. We also want to look at reports and think about prior component separations, right? This is a patient who came to see me with a prior external oblique release. And you can see that the linea semilunaris here has been completely divided on the left-hand side. There's a rectus and we've got lateral muscles here. And so, looking at and understanding what has been done to patients before is certainly helpful. We obviously want to make sure we account for all the defects on an imaging study as well. This is a patient from my own institution who had a read of a midline hernia. So we can see rectus abdominis muscles here. This is from a fan and steel incision from a C-section previously, and we can see content exiting through, but there's also something going on here on the right linea semilunaris. And if we go just a few cuts up, we can again see the rectus in blue, and we can see a partial thickness defect here. We've got a transversus and an internal oblique that are no longer inserted, and we've got an intact external oblique that's very, very bulgy. Our report for this only mentioned the low midline hernia, and the problem comes in is if you go and fix the low midline only and completely ignore this lateral defect, I assure you this patient's going to come back in short order and say, what's going on here at this lateral aspect? It's also nice to know radiographically where mesh is located. And so we're going to spend the next few seconds here talking about mesh. Mesh can sometimes be very easy to see radiographically. When you get in the operating room, this patient we chose to do open because of our interpretation that there was actually bowel on both sides of the mesh, which is never a good sign. And you can actually see here's some mesentery heavily stuck to the non-coated side of this mesh. And you can also see that when you take that mesh out, that looks pretty much what it looked like on the CT scan, right? So you can actually see the mesh contracture here as well. Identifying mesh on imaging is one of the hardest things to learn how to do. And so I want to teach you guys ways that I've learned to do it. Number one is that the appearance of mesh on an imaging study depends entirely on the density of things that are surrounding the mesh itself. And so when there is fat surrounding mesh, it is very, very easy to identify. We also want to learn how to look for non-anatomic folds and wrinkles. And obviously, radiopaque fixation makes it super easy to find where the mesh was at least initially intentionally placed. But as I said earlier, you as the surgeon have the advantage because you can read the old operative note and understand what planes, what location, and maybe even what size mesh to get a sense of how big should I be looking here. This is a table from the SAGES Manual of Hernia Repair, which was part of the SAGES Master Series that just came out. This is a slide that one of my former fellows, Ryan Musa, put together and modified from some earlier work by Carl LeBlanc. The bottom line is, all meshes can be seen. There are some that are poorly visible, and obviously the lighter the weight of the mesh, the more macroporous the mesh, and the better that mesh is in apposition with muscle, the harder it is to see. And so unless there's an inflammatory response around it. So meshes like Ultra Pro, soft mesh, these ultra lightweight macroporous meshes are very, very challenging to find. So let's look for some meshes here on imaging. The arrow, obviously, we'll be pointing out the mesh on these slides. This is a patient who had a previous laparoscopic repair. And we have the op note, and so we know that they did not take down the falciform ligament. And so what you see here is a piece of mesh identified by non-anatomic folds and wrinkles, right? Humans don't wrinkle like this. And you see mesh of the falciform ligament, you see fat of the falciform ligament above the mesh, and you see intra-abdominal fat here, some omental fat below it. And so this mesh is now pretty obvious as mesh once you know how to look for it. Here is a patient who had a preperitoneal repair of an incisional hernia. And again, the mesh is visible because we've got intra-abdominal fat and some preperitoneal fat in the space of retzius here. But we can also see this sawtooth wave pattern, which is a non-anatomic wrinkle, and we can see the mesh behind this muscle. But I also want to point out that this muscle is partly fatty replaced. This is a denervated muscle. Compare the right side to the left side, and you can understand a little bit why we're able to see this. These are the epigastric vessels here, which if you do inguinal hernia surgery, have a nice fat pad around them. So finding the fat pad around those epigastric vessels allows you to, again, see the ending part and the confines of where this mesh is located. Here's a piece of mesh that was laparoscopically placed. This mesh is visible because it has EPTFE in it, and we know that that makes it very easy to see no matter what it's against. We can also see it's got radiopaque fixation, and we can see a recurrent hernia here in the midline. If you look at this imaging study, you can also tell why this hernia recurred. The mesh is not centered. And if I asked you to tell me what side of the patient the surgeon was standing on when they did this operation, you would tell me they were standing on the left and they short sheeted the mesh to the right, and that's why we have a recurrence. And that's exactly, without even reading the op note, you can kind of make predictions about recurrences based off of the imaging study alone. And that's exactly what happened in this patient's case. Here's an onlay piece of heavyweight polypropylene mesh. This mesh was secured with a skin stapler to the fascia, but not actually to the fascia, because if you look, you can see that there's a clear layer of fat here between the mesh and the muscles itself. And that's what makes this mesh very easily visible. It's got fat on both sides of it. This patient did not have a recurrence of a hernia, but it was a nice onlay imaging study to show. Here is a patient who had an inguinal hernia repair done laparoscopically, who has severe debilitating chronic groin pain. So we can see the mesh, and we can also see that this mesh is heavily scalloped, right? We can see there are areas where there are big folds and wrinkles in it. And we can actually see some radiopaque fixation here really, really low in this dissection. And if you read the operative note, the surgeon actually dictated in the note that they placed tacks in the triangle of pain. They actually said it. We placed tacks safely in the triangle of pain. Well, not so safely because this patient has chronic pain. In this this is a different patient here who actually had the same operation. We can see a heavyweight piece of polypropylene here. Again, we can see some fat in the retromuscular position showing us the mesh. We've got a nice internal comparison here on the contralateral side. And here we see appropriately placed tacks well above the iliopubic tract, above the anterior superior iliac spine here in a patient who's got no symptoms, no pain and no recurrence. And if we go a little higher up on this patient, we see 4 well-placed tacks at the location where a TAPP flap was made. So now, again, without even looking at the patient's op note, we know what kind of inguinal hernia repair they have. Here is some retromuscular mesh, which is very hard to identify alone because it is against muscle and it is isodense to the muscle, but we can see a few things. Number one, a number of clips were used to control small blood vessels in the retromuscular pocket. And so we can see that radiopaque clips. This patient also has had the mesh divided down the midline for a subsequent open operation. And as a consequence of that, they actually have a fracture of the mesh in the midline and a recurrent hernia here. Here we see a piece of laparoscopic mesh against, well, not really against the abdominal wall, kind of free floating a little bit. This was a patient who had a laparoscopic repair done without defect closure, without clearance of fat from the abdominal wall, and with absorbable non-radiopaque fixation only. And if I told you all of those things, you would look at the scan and say, yeah, I think I understand why that hernia recurred. But you can also look at the scan and realize that surrounding the mesh, at least on this cut, there's really not a lot of adhesions, right? You've got some omentum nearby. The bowel appears to be clear radiographically. And so if you were going to approach this as a redo, minimally invasive operation, I think you've got some good evidence here that says this is going to be able to be accomplished in a reasonable amount of time. This is a patient of mine who has a CT scan interpreted as diastasis of the rectus abdominis. That is not what this is. This patient actually had a staged reconstruction. They had a lot of complex GI tract work done in the setting of a very large hernia. And we used a piece of bioabsorbable mesh to bridge the midline, a straight up bridge. And so again, these non-anatomic wrinkles should tip you off that this is actually a mesh product and not native patient anatomy. Now, here are some retromuscular operations where it's very, very hard to see the mesh. This is a retrorectus operation with a lighter weight piece of polypropylene mesh. You really can't see the mesh here. The only way you can tell that anything has been done is that there's some scarring here in the midline, and the rectus muscles kind of make one big motor unit in the midline, and that's a tip-off of a retromuscular operation. This patient similarly had a transversus abdominis release. It's a little bit challenging to get a sense that there's any mesh here at all. And that's true even in a patient who's got some denervated rectus abdominis here, like this patient does. Very challenging to tell that there's actually mesh here at all because of the lightweight macroporous mesh. About 3 years ago, I stopped using all sort of suture or tack-based fixation for my retromuscular operations and switched over to doing these with Tisseal or fibrin sealant. One of the things I noticed is that you can now identify the mesh very easily on these studies. And I say that because, and we saw this earlier, you can see this sawtooth wave pattern that I'm making out here behind the muscles. So this sawtooth wave should tip you off that a repair was done here without fixation, and the mesh is a bit wrinkled. The same thing here, these wrinkles right here should give you a little bit of tip off that there is mesh here. These are extremely, extremely subtle signs that the only way to look at this is to actually have an operative note and get a sense of, what's going on. It would be a challenge for anybody, even an extremely senior radiologist, to look at the scan and say, this was a patient who had a hernia operation. But knowing that the rectus muscles kind of make one big motor unit here, seeing some ongoing and residual inflammatory stranding here, and then seeing these folds and wrinkles are all things that tip me off about what's going on. I think the study also shows something interesting, which I'll talk about in just a second, which is we talked about intra-abdominal adhesions. If you look behind this left rectus abdominis, you can see actually a pretty clear plane here separating the bowel from the abdominal wall. If this patient needed another operation, I would look at the scan and get a sense that there's a clear plane all the way around and probably contemplate doing their surgery laparoscopically. even though their abdominal wall reconstruction was done as an open operation. Making life a lot easier are these visible mesh products, which are not yet available in the US. I don't believe they're available in Canada yet either, but are used in Europe to some degree. I showed you a version of this mesh earlier on the MRI imaging from earlier. This is what these look like on imaging studies, and you get a sense of exactly how the metal portions of this mesh show up on these imaging studies. Despite all of that, and despite all of sort of my expertise in looking at imaging studies and planning, I think, good hernia surgeries, sometimes things get missed. I'm drawing here with an arrow an area of the abdominal wall on this patient. This was a patient who I was performing a robotic transversus abdominis release on, and I had done the entire operation. I'd closed the posterior layers of the reconstruction. I was closing the anterior fascia. And as I reached the bottom section, I was sewing on the ceiling. I could not make the needle go through I couldn't make it go through the fascia. There was just clearly something wrong, and I was not happy. And despite the fact that we were near the end of the case, I elected to convert to open. And when we did, what we found was this piece of balled up inflammatory tissue with some permanent suture material there, surrounded by purulence, which turned out to be MRSA. And so that little area correlated with this small section on the CT scan, which is easily mistaken for a loop of bowel on this non-contrast, totally non-contrast imaging study. So things still do get missed. A few final questions that I like to ask on all of these studies and then look at the CT scan. If the patient has had a history of a bowel obstruction, I want to know, is the hernia, is the mesh really the source of the obstruction, or do I need to do a more complete enterolysis? And that helps me decide if I'm going to do something robotically or laparoscopically, or whether I think I would be better to do it open. I also try to figure out if there's areas where I'm going to find dense adhesions. For example, some operations and some operative notes will actually describe resections of portions of the abdominal wall. The most classic example are people who get radical cystectomies, where urologists will strip the peritoneum and sometimes the transversalis fascia below the level of the umbilicus to remove all urachal and umbilical remnants from the patient. And what you get is what we see on this scan here. This is a patient who has a cystectomy a little bit higher up. Yes, there's a hernia out here, but what I'm looking at is this area where I've got muscle and I've got a loop of bowel clearly stuck at this level. There's no anatomic plane separating these two. And I know that at that area, I'm going to have a very challenging anatomic dissection and no easy planes to work in. Whether you decide to do that lap or robot or open is entirely up to you, but you can look at the scan and be prepared for that. Here's another patient in whom we knew that portions of the right posterior rectus sheath had been divided laterally and swung anterior. So this is actually the posterior rectus sheath that has been swung anterior in a trapdoor fashion. When people do that, exposing bare muscle to the peritoneal cavity means that things get stuck. And so we look at this rectus and we say, okay, there's going to be stuff stuck to it. So what's here? Well, this is the patient's duodenum. This is D2. This is actually the third portion of the duodenum stuck to the patient's rectus right here. And this is their gallbladder. All right. I'm going to go real slow. I don't like making enterotomies, but I really don't like making duodenotomies during my hernia surgeries. And so in this particular patient, when we get in, you can see the duodenum is just absolutely plastered to the back of this rectus as we approach it. This took almost an hour to very safely and very carefully get down. And again, I think knowing that it's the duodenum going in means that at that area from minute zero, you are paying attention and not causing problems that you're going to regret later on. I also like to try and figure out and guess whether I'm going to be able to close the fascia. I showed you some scans earlier of a lax abdomen in a patient who has a non-lax abdomen. You can, once you do this enough, you can get a sense of whether the abdominal wall is going to close. There are obviously a lot of advanced things you can learn. We talked about loss of domain and measuring hernia volumes. You can look for other non-hernia related findings in the solid organs if you want. You can learn how to play with the Hounsfield units. And obviously learning ultrasound and learning MRI have their own tricks. I would advocate starting with CT scans. We talked about sarcopenia and fat distribution. And that leads me into the concluding part here on radiomics. Radiomics is using things that are on the CT scans algorithmically to determine data that you would not be able to figure out without that imaging study. And I'm just going to give you some pictures here to show you some things that we think about. So, A is the baseline CAT scan of this patient. Okay. In image B, what we are looking at is the volume distribution of intra-abdominal fat to extra-abdominal fat. Okay. So we're looking for patients who have, fat distribution more in line with a metabolic type syndrome. In image C, again, you see the same fat distribution. In D, what we're looking at is measuring the fat that is involving the liver and the spleen, looking for, again, intra-abdominal fat distribution in solid organs. Okay, so why do we care about this? Well, what if this information, knowing a patient's fat distribution, knowing whether they have a fatty liver, even if they don't have clinical or laboratory signs of it, can help predict an outcome? So if you look at non-alcoholic steatohepatosis radiomics, we know that patients who are not diabetic, but who have NASH on their hernia imaging studies pre-op are more likely to have post-operative hyperglycemia. Steatosis is independently associated with the development of post-operative hyperglycemia, as were surgical site occurrences. So if you're a patient who's got NASH, you're more likely to have a seroma. Does that change the hernia repair that I'm going to do? Maybe, but it also does change a little bit of the discussion and maybe a little bit of the drain management in those patients post-operatively. What about adverse outcomes? Well, can adiposity predict this? Yes, it can. If you are a type 2 diabetic and on your imaging studies have two markers of adiposity, like the two I showed you earlier, that is predictive of a surgical site occurrence, including surgical site occurrences that require a procedural intervention, like opening up a wound or replacing a drain. If you had type 2 diabetes and a fatty liver versus neither of those two things preoperatively, you were 11 times more likely to develop a surgical site occurrence and 42 times more likely to need that surgical site occurrence managed with a procedure. Again, this may influence not only the type of surgery you offer a patient, but how you discuss complications with a higher risk patient versus a lower risk patient. So we're trying to help stratify. What about the need for an emergency operation? Can radiology help you with that? It sure can. This group in 2017, Music et al. Actually looked at the odds ratio for emergency surgery. So you get some points if you have a high BMI, but then if you look at things like ascites and the CT scan angle, and by that, what they're measuring in the angle is this. So in 4 here, they're measuring a CT angle that is a very narrow angle, okay, versus an even more narrow angle. So this is one that's less than 30 degrees here. So this gets 5 points. And you can also see how they're measuring the height of a hernia sac here. So 0.4 times the sac height. That gives you as a score. And if you plot that score out, patients with a score of less than 5 have a very low likelihood of needing an emergency surgery. Patients with a score of 10 have a 2.5 times odds ratio of needing an emergency operation. Is this helpful? Sure. Because if you meet somebody in clinic and they have these criteria, you might move them to the front of the line in terms of hernia surgery. What about during a pandemic when you've canceled all of your hernia cases, as I expect to have to do here in the next couple of weeks, and all of your patients need to get reordered on the schedule? Who do you put first? Who do you move to the front of the line? Well, how about you move the patients who have the highest odds ratio of needing an emergency operation? That would make a lot of sense. The newest kid on the block is 3D imaging of the abdominal wall, and a lot of this work comes from my friend Philip Moisems, who will actually have an entire book chapter on this in a textbook of hernia radiology that I'm actually editing this week for Springer and hopefully out next year. These images are very helpful, I think, for a few reasons. One is if you're a hernia surgeon who doesn't look at these scans a lot, I think anybody can look at this scan and say, hey, I got a hernia in the midline, I got a hernia at the edge of the rectus. These make the interpretation a lot easier. These are also very helpful tools to talk with when you show them to patients. Hey, this is what your rectus abdominis looks like. Yes, you've got a small umbilical hernia, but look at the gap between your rectus muscles above versus below the umbilicus. What about these lumbar hernias, which again, very kind of hard to interpret and understand, very challenging to feel. The 3D imaging of these is very helpful. And then obviously looking at the volume and what's in a hernia, you can actually see the stacked loops of bowel here in 3 dimensions to give you a better understanding of areas where, as I showed you earlier, where there may be a lot of adhesiolysis to undergo? How about this patient who's got actually omentum on the top here of this hernia sac? If you're going to enter this hernia sac, where would you enter safely? How about right over the omentum, as opposed to entering directly over where there are solid loops of bowel? I was going to spend the last little bit here going over some CT scans with the senior residents. We're close to the end of the hour, and so maybe what I'll do is just go over one scan myself and just have everybody kind of look at it on their own, and then we can spend the last few minutes here maybe doing some questions. Let's do this one. I think this is the one I want to do. This is a patient who presented to my clinic with a right-sided bulge after a gallbladder surgery. Okay, I'm going to let you guys look at this, and I want you to think about what you see on the scan, and then I'm going to go through and interpret it. Melena, you're one of the few people with your camera on, so I'm watching faces. Oh, Lane just turned hers on as well. So, yeah, so you know, there's obviously a lot of things wrong with this scan, okay? And you know, obviously getting the op notes is very, very helpful, but honestly, you don't actually need the op notes to interpret most of this, okay? So let's just start up top. So when I go through a scan, I usually start at the top and I work my way down through the middle. So we're looking at midline stuff. So we have some midline hernias here, and these are potentially port sites from her laparoscopic cholecystectomy. There's at least 2 of them. But then as we get down toward the umbilicus, we see radiopaque fixation, which is obviously going to be on a piece of mesh. And this mesh is visible because there's fat on both sides of it. You can see some non-anatomic wrinkles, and we can see the edges of the radiopaque fixation. Now, keep in mind that most people fixate mesh in a double crown. And so if you think about that, here's the top of the circle, and then it goes a little wider. So look at the edges of the mesh, and then here's the bottom of that circle. But then shortly thereafter, we've got another piece of mesh starting. So there's actually one piece of mesh here near the umbilicus, and then another piece of mesh right here in the midline, which has its own tax and its own double crown. And we'll follow that down the midline, down to about here. But then look, that mesh stops, and here's another piece. There's a third piece of mesh in the midline right there. So there's 3 pieces of mesh in this patient's midline. Let's go to the right side now. This is the only hernia that she was complaining about. This is just a laparoscopic trocar site that happened to actually go directly through the linea semilunaris. Look at how thin her semilunar line is on the left. So that's a comparison. Imagine putting a 12 port through the middle of this and not closing it. But look at the consequences of that. Not only is there a big hernia, look at the rectus is, I'm sorry, the external oblique has actually been completely disinserted, right? This is a normal oblique for her. It should insert here. This is a completely disinserted oblique with this large abdominal wall defect with bowel content that extends up above the costal margin. So it actually extends above. So that's a challenge. And then as we come down, let's look at what's going on down here. This was an old portside hernia from a laparoscopic gynecologic procedure that she had had. So that also went through the semilunar line in the left lower quadrant. But let's just count the pieces of mesh that are here, okay? So there's this midline mesh that comes over, but there's clearly a second piece of mesh, maybe from here to here. So there's another piece of mesh there. And then a third piece somewhere right about here. So there's like 6 pieces of mesh in this patient, lots of protax. We've got hernias spanning the midline all the way up top. We've got semilunar line hernias and lateral zones on the left and on the right, okay? So challenging operation, going to require a lot of mesh removal, and it's going to take all day. So like this is like you're the only operation I'm doing that day, and we're going to pack a picnic lunch because this takes all day to reconstruct. But knowing that going in means that like you're not going in to fix this and then completely ignoring all of this stuff down below. So this lady is very happy. She's completely reconstructed and has no recurrent hernias yet, but you know, obviously requires some long-term follow-up. So I'm going to conclude by saying, I do this regularly and you can too. These are 2 Rembrandt photos, again, from the same gallery we went to on the same topic, one at the very beginning of his career with not a lot of detail in it. And then one later in the career, much greater detail, same artist, same subject matter, but just a lot more clarity based on better understanding and mastery of craft. So I would encourage you guys to think about your CT scans and look at them quite regularly. And you can do this too. Delighted to answer any questions we have coming up. And then if there's something that doesn't get answered, please feel free to email me. You know, you can reach out to me for a DM on Twitter as well. I'm happy to chat. Thank you.
Well, thank you very much. I'm hoping we're getting some virtual applause here. I'm also getting lots of people who have been texting me. What a fantastic, excellent, amazing talk. Thank you, thank you. Thank you very much for that very interesting talk, and I hope we can answer a few questions. So does anybody have questions? I'm not seeing any in the chat yet, so feel free to either raise your hand or just speak. Any questions?
Hi, again, fascinating talk. It's really amazing. It's a new thing. Like we read about these topics and applying images in hernia repair, but it's usually scattered all over the literature, and not. It's very nice to put it in one place and talk about it at once. I have two questions. So, first of all, the last CT, how did you repair what approach did you take?
Yeah, I mean, the dirty secret of life is I really only know one way to fix hernias, right? So that was an open posterior component separation with a tar, okay? Yeah. You know, getting all that mesh out, like I'm okay with a robot, but that patient has been a victim of previous laparoscopic surgery. And, you know, sometimes just doing it open is the right way. And certainly to get the mesh overlap needed, to get all that mesh out safely was an open tar. You know, think about that left lower quadrant hernia in particular, getting overlap there is really, really challenging. You got to do a complete dissection of the myopectoneal orifice. So just a really thorough sublay repair. Okay.
The other question, so in a you know, run-of-the-mill hernia that probably needs a retrorectus repair, what kind of measurements do you do? Now, there's a lot of measurements that we talked about. What is most important to you?
Yeah, I mean, that Carbonyl ratio, honestly, is probably the most important thing to get an understanding of whether it can be done as a straight up retrorectus operation or whether some additional release of components might be necessary, okay? And that will help you figure out fascial closure. It'll also let you measure preoperatively the amount of mesh overlap you're gonna get, right? If you measure somebody and they've only got 4 centimeter rectus muscles, that's not enough overlap, right? You know you're gonna have to do something else or change your approach. I get really lucky. I get these people around here who have 10 or 12 centimeter rectus muscles. And so they're awesome candidates for an ETAP repair. You know, the biggest thing that I look at in those patients is if I'm doing an ETAP repair on them, sometimes that posterior sheath is under a good bit of tension for closure. And so understanding patients who you may want to release the posterior lamella of the internal oblique without doing the actual transversus release, kind of that intermediate step to TAR as a tension alleviating maneuver on the posterior sheath, is the next thing I'm trying to figure out if I can interpret radiographically. I haven't figured it out yet. I'm still fooled.
I'll ask you a last question, and that it's a bit of a personal bias. Do you think if you do a laparoscopic ETAP, you would have, or a ETAR, like if you do a laparoscopic retrorectus repair, do you think there is a higher chance you're going to end up with a TAR as opposed to an open?
Yeah, I mean, probably. The short answer is probably, right? And that has to do with the ability of open surgery to probably close defects under a little more tension than most of us would be comfortable doing, certainly laparoscopically, right? Lap defect closure is technically really, really challenging. And so a lot of times, you know, what we see, listen, I don't think it's wrong though. Like, I don't think it's wrong to offer somebody a lap TAR knowing that they would be an open retrorectus, because, I mean, yes, you're separating components, but you're also reducing significantly the wound morbidity of that patient, right? So there's advantages and disadvantages to all of these techniques. And you know, listen, I've had patients who I had somebody in clinic last week, I offered them a robotic TAR, and he was like, nope, because I want this scar gone, do it open. And I was like, okay, I mean, so we talked about a hybrid operation. So I'm going to do most of it robotically. I'm going to open the last part. I'll take the skin off. We'll debride the fascia. And I'll close it and place the mesh open and just sort of minimize the time that he's open. But he really wanted an open operation.
Good.
So we have one question in the chat and one more question, and then we'll move on for the rest of the program, if that's okay. I know we're going a little bit over. Who is HA? I don't know who HA is, but HA has a question. When is closing rectus diastasis absolutely needed for appropriate hernia repair?
Yeah, I don't think anybody has the answer to that question. I mean, does a small umbilical require a complete reconstruction of the diastasis? I mean, I don't really know, but I've definitely seen lots of people who didn't have them closed who have recurrences. And that's probably a bias on my part because most of my practice are recurrences. I think the biggest issue with the diastasis is not specifically about the diastasis closure, but about how you are fixating mesh to the diastasis. A lot of the recurrences that I see are at the upper aspect of a previously placed mesh where a transfascial suture or a tack was put into that diastatic fascia. And what you wind up getting is suture pull through and a recurrent hernia above the old operation. So I think if you're going to fixate mesh in that fashion, you're kind of obligated to close the diastasis. If you're doing a sublay repair where you're floating the mesh in the sublay plane without any fixation, you might not need that, especially since you have such wide mesh overlap in those planes. So there are probably some circumstances where it should be done and some circumstances where it's unnecessary based off of your approach to the operation.
So, and one final question for this segment, Namdar, one of our alumni MIS fellows. Namdar, go ahead. Unmute yourself, please. You're mute.
Hello, everyone. First, I just want to say, I think this is actually like probably one of the best 1 hour talks that I've listened to or
Thanks.
Zoom over the last, because I just find it such a nice balance of interdisciplinary. However, you still have to have the judgment of your colleagues in a different discipline because it's all very translational. And being an independent practice, I think it's such a very important thing is to be able to read your own scans. Oftentimes you won't have a radiologist sometimes in the middle of the night. And so this is such a good means of or an algorithm to go through to be prepared before going to the operating room. One of the questions I have for you specifically, and it stems from one of the cases, and I don't know if she texted you back, but I find that I also have a lot of difficulty with the subxiphoid when you have this subxiphoid defect that just, I try to at first, okay, the patients are sick, let's ignore it until they're better. But then by the time they come back, you get a huge sac. It's tough to pull it together. I think barbed sutures are probably like one of the best things I've ever come across as far as making the job easier. But what would you have suggested for your colleague? And what specifically would you say with a subxiphoid when you look at your scans? Are you going to actually, what's your judgment that gave you the thought that, geez, she's going to have a tough time pulling it together?
Yeah, I mean, it's a challenge. Large defects in the immediate subxiphoid region are probably the hardest thing to get closed simply because the rectus is attached to a bony prominence and you really can't move those costal margins together. I think at the end of the day, it's less about predicting whether you can and can't get it done because that's going to wind up being a game time decision. But in the operation, already having recognized this may not come together. And so that for me means saving elements of the abdominal wall. So in that particular case, I advised her to leave the hernia sac until the very end, right? That way, when she does a sublay operation, she'll have wide mesh overlap. And if the fascia can't come together, she's going to peel the hernia sac off of one side of the abdominal wall and sew it to the contralateral rectus so that the mesh is now completely excluded and is in a complete intact sublay plane, right? That's a Andrew DeVoe from Scotland style hernia surgery. Fascia is not closed, but the mesh has got living stuff on both sides. And so if a wound complication happens and you have to open the wound, the first thing you're looking at is not the mesh. I don't mind a bridged reconstruction if there's no other option than a bridged reconstruction. So, if it happens, just have your backup plan for how you're going to cover the mesh. That'd be the best advice.
Thank you very much. Again, great, fantastic stuff.
Thank you.
All right, so we're going to be moving right along. I just want to say, whoever needs a break, obviously take a break. We didn't schedule breaks in here because this is Zoom.